Good afternoon, everybody. Thank you for joining us. I think we've got people trickling in, so this should be a lovely conversation. As people are running a little late, the three of us have been chatting away and getting to know each other a little bit, so it's good stuff. So maybe we'll go through introductions first. Dina, why don't we start with you and introductions, where you are and what you do, please.
I'm Dina Ben Yehuda. I'm from Jerusalem. I'm the Dean of the Faculty of Medicine of the Hebrew University in Jerusalem, and I'm the chair of the hematology division in Hadassah Medical Center in Jerusalem.
Thank you for joining us. I know it's a bit late over there, so we really appreciate it. Mark, over to you.
Sure, thank you. I'm Dr. Mark Jarrett. I'm a recovering rheumatologist. I am the Chief Quality Officer and Deputy Chief Medical Officer for Northwell Health, which is a 23 hospital health system in the metropolitan New York area.
Thank you. So for the audience, we're going to discuss a few things around healthcare trends, maybe what we're seeing, get some guidance around things like innovation, etc. If you have any questions, please just put them in the Q&A. I'll keep an eye on things on the Q&A. So that way, if you've got something burning in your brain that you want to ask our two rock stars that we've gathered here today, you can put them in the Q&A and I'll make sure I get to that somehow. But there may be questions I may not pick because I may not want to pick them. So there you go. I have all the power in the world this afternoon, which is great. So Dina, let's start with you. You've done some amazing stuff and now you're a dean. What are some of the things you're sort of looking at as you look at innovation and what you're training the people at the university? What are some of the things that you think are most important at the moment?
So it seems that medicine is undergoing like tsunami in the past few years, trying to change the paradigm from one size fits all medicine to precision medicine. So as a dean, I see as one of my missions and role to educate the future physician to this new care paradigm, which is mostly rely on understanding the difference, meaning when I see another patient with lymphoma, I will have to understand what's the difference between him and 1,000 other patients, and knowing it in depth, not only in the clinical way, but also on the DNA level and the biomarkers, microenvironment, and so forth. I'll be able to give precision diagnosis, precision treatment, and more importantly, even precision prevention. So I think that my role now is to prepare the future physician for such medicine. And one of the things that we need to understand the difference involves big data, bioinformatics, and computational medicine. So this is something that I'm very busy at in my faculty.
I know you mentioned before we started that you're really focusing a lot on some of the technology and the computational side of things. Is this new, or have you been doing it for a couple of years? How's this been introduced?
I mean, we have computational biologists in our university, and we have a very strong computational faculty in the university. But in the Faculty of Medicine, we are very hard on it for the past like 3 years or so.
Amazing. Great. Mark, please introduce yourself and as far as what you're doing with respect to some of the digitization that's going on.
So my day job is the Chief Quality Officer for the health system. So obviously, data is very important. You don't know if you've improved unless you can measure it. So we've always needed data. In the past, we lived in the world of abstracting data from charts. Now using the electronic health records, which are very, not designed for this, has really been the emphasis that we've had. Remember, most in the United States, electronic health records was designed for meaningful use, which means that was the way we got paid. But they were not designed in a way that made them both patient-friendly, in the fact that doctors don't have to sit there, typing away in order to, instead of interacting with the patient. But more importantly, the data was not designed in a way that was easy to retrieve. So the same piece of information may be in 6 different places, and one person could put it in one place, another person could put it in another place, and unless you're able to pull all that in, you never have a true picture of what's going on with the patient. So we've been working a lot on that. We're starting to introduce artificial intelligence and machine learning into our processes. We're recognizing that it's a tool which we're going to need to use. But I think what we've done now also, and this is especially because of COVID, is really work much more on predictive analysis. And that's something we really didn't do before. Yes, we had early warning systems if somebody went into sepsis, et cetera. But because of COVID, we need a predictive analysis in order to maintain the bed flow and patient census in the hospitals. And at the peak last spring, our health system had about 3,500 patients with COVID in the hospital, of whom 800 were on respirators. Needless to say, some places were much more overloaded than others. We needed to know where we were going to be later that day and the next day for that hospital, where we would move ventilators. And that science of predictive analysis, which is now being used more aggressively for the rest of care, has been another way. And I see that as the first step as we go through machine learning and artificial intelligence. So there were a lot of lessons learned from COVID. My hope is that these lessons learned don't get lost over the next year, the next year as things hopefully settle down and we go back to the old normal instead of the new normal.
So do you guys, and perhaps Dina, we can start with you, the use of AI and machines to do these kinds of predictive modeling, will they help the future physician that you're training in your university to do their job better? Will it change the requirements they have, which is learning more of these machine tools and not less medicine? Is there a fear of that?
I'll elaborate later of what we are doing in order to educate these physicians, because I think that it needs special education. But in general, I'm sure that the AI won't substitute the nurses, physicians, and other healthcare professionals. And I believe that in the AI era, patients will need more their physicians and nurses, and I think that there is no substitution to talk with each other, to touch the patients on physical examination, I mean, and I'm sure that patients will need us more. So I'm not afraid from the AI.
Great. But Mark, you talked about it from a cybersecurity and data perspective earlier, in a forum that we were in together. Are some of those things and the privacy things top of mind as well as we hurtle down this road?
Yes, I think they are. I mean, even before we get to AI, everything in the hospitals is becoming electronic. Every pump is, every sensor is, and the ability of people to alter the information, the data coming from them is very worrisome. As we get to algorithms for AI and machine learning, it is not that the people the hackers who do the bad stuff are usually one step ahead of everybody else than the white hats. And it becomes really dangerous if we don't have the right controls to make sure that information has not been transformed into something that now becomes dangerous information rather than helpful information. But going back, to what the dean had said, I really agree that we need to keep the humanity in it and keep the old clinical sense in it, because even now with just simple lab tests, we always teach, medical students and house staff, residents, trainees, that if a lab test comes back and makes no sense, it may not be real. Don't go down the rabbit hole of treating it. First, maybe repeat it, because maybe the lab made an error. And I think we're going to have to do the same thing with artificial intelligence. We're going to have to look at AI and machine learning and say, does that really make sense? And, not forget about it, but question it. The humanities, and for those of you who are old enough to be original Star Trek fans, Bones had the tricorder from which he could make all the diagnostic information. But what made him interesting was he was a physician who interacted with people.
A grumpy one.
And I think we need to keep that sense, not only for the humanity and the sake of the patients, but also for the diagnostic issues, that if we don't, then we're just, we're reading pieces of paper and we're not making decisions based on also what clinical sense we have of what's going on with the patient.
I see you nodding away. Do you want to add to that?
I think that it's like a two-edged sword, because on one hand, I think that the AI will help a lot. My concerns are humanities. I think that we shouldn't forget about it, and I can tell you later on what we're doing in the faculty for it. But I have to say that I'm also afraid from physicians that will make a lot of obstacles for it to develop. And when I did my fellowship in Memorial Sloan Kettering in New York, and when I came back to Israel, I told my superior hematologist that I learned a method with which I can allocate one leukemic cells out of millions. It's PCR, but it was a very big deal at that time. So they told me that it's nonsense. I should look at the microscope, and this is the only way to diagnose the leukemia. This is even not such a big problem like my friends, my surgeon friends, who came back from the States at the same time and told their superiors that they learned a method where instead of opening the abdomen, you can do three little cuts, and you can do all kinds of operations. But there was a saying at that time of the surgeons that a big surgeon, big cut, little surgeon, little cut. So years elapsed till people use this method in Israel. So my concern is that if we won't have the right education, physicians will be afraid from the AI, and they won't let it develop very well. And I heard from one of our high-tech CEO who developed a method to allocate a small bleeding in the MRI, that the main obstacle were the imaging physicians that didn't let him develop it very easily. So one of the things that I did to avoid it and to try to overcome it, we decided to start a program where the very, very smart and wisest students, they start studying medical school from the first year. We are studying 6 years. So in the first 3 years, they are doing their first degree. And during these 3 years, they study medicine and computational science together. Then they take 1 year to do only computational science, and they will be the computational physicians of the future. And because they are not just computational geeks, they also they want to be physicians. I think that they will show the physicians the right friendly way to use AI. Because I think that if physicians will be afraid from machine learning and AI, all the developments in the world won't help the patient that will come to the office of such a physician. And it's pity. So I think that we should, and we are teaching now all the students in the medical school, digital medicine and computational medicine, in order that they will be familiar with it and won't be afraid from it, even if they are not computational scientists.
But surely, and Mark, that for you, you know, in listening to Dina and what they're doing at the university, I see pockets where it's actually very good, you know, predictive modeling or predicting things that we would have waited or gone to see every patient to keep an eye on them. And now the machine tells us which one to focus on, because from a predictive modeling perspective, you know, that person's more likely to, you know, have acute kidney infection, let's say. I saw that algorithm, for example. Are you deploying any of those things in the hospital, and are you seeing a change in care delivery? You're on mute, Mark, for some reason.
Myself on mute. I apologize.
No
yes,
worries.
we are deploying that.
Yeah.
I need AI to remind me to unmute. But anyway, we are deploying it. So, for example, we're using it even in simple things like, you know, using the information gathered. When is the patient expected to be discharged? So we start making plans. We're using it in a lot. Which patients maybe can leave the ICU that day to go to a regular floor, which ones need to go to an ICU. We're starting to pick up, so you know, information that says it. So we're starting to use it. We don't get a lot of pushback. I think the reason doctors push back is, especially older physicians, much less the younger ones coming out, is the fact that they're fearful of cookbook medicine. That's the thing they always talk about. And what we try and teach, it's not cookbook. You know, a good chef doesn't follow the recipe to the letter. A good chef knows how to interpret the recipe. And we try to do the same thing with our doctors. You know, COVID did a lot of terrible things, but one of the good things we learned from it was that I think physicians realized that a certain amount of standardization, a certain amount of digital information actually made their lives better and made their care better. Where before this, you know, everybody kind of thinks my way is the right way to do it. And I think what we've learned now is, yes, there can be more than one right way, but if we all do it the same way, one of those two ways, we can look for variation and find out why things aren't working well. And I think we've learned that over the last year or so. And you know, and also the value of doing studies. You know, that seems intuitive, but it really wasn't. Certainly back last spring when, you know, we had thousands dying, we literally threw the kitchen sink at everybody. Instead of trying to standardize, instead of doing studies, people were, you know, reading a paper about, you know, 13 patients in, you know, southern Finland that they gave this drug to, and they all did great, and therefore everybody wants to use it. And the shame of it is that what we learned was, by not applying appropriate information, appropriate science to it, not only did we give a lot of futile things, and clearly hydroxychloroquine is the classic that everybody knows about, but other things, vitamin D, things like that. But really what it came down to is we started using on ICU patients multiple medications, many of them stuff that falls into the rheumatology area. And when giving multiples of those medications, not only didn't we make the patients better, we probably lowered their immune system. They then developed super infections and maybe hastened their death sometimes. It was done out of frustration and desperation, but I think this event has transformed a good chunk of the physicians out there to maybe look at things differently, and now be much more, you know, sensitive to the importance of digital information, or any information, but certainly digital information, and using it in studies to really decide what treatments we should be giving. Another example is, you know, using therapeutic anticoagulation for people who have severe COVID. Originally, everybody put people on prophylactic anticoagulation, but since we saw so many clots, people thought we should be giving therapeutic anticoagulation. Well, just major study came out last week that said that was more harmful. So I think physicians are finally beginning to realize the way they started out, in medical school of believing in science, we want the humanity there, but the humanity needs to be supported by a foundation of science. And I think that's something that has really changed and makes me somewhat hopeful that this digital revolution will now be more acceptable to the masses of physicians than it was 2 years ago.
Dina, I see you nodding away in some of these conversations, and Suzanne has posted an interesting thing in the question and answer about her recollection that you had a vast array of research and data that you had access to that others didn't. Does that help you in educating these future physicians? And are you continuing to use that data in different ways to do that?
So I think that one of the important things that Mark just mentioned is that it's very important that physicians will have a very strong affiliation for research. I think that research physicians are in a way different from other scientists that are going to the lab. I always say that each and every subject that I investigated in my laboratory, I can tell you the patient that his needs, or let's say his unmet needs, started the research. And I think that one of the roles of us as educators is to have more and more physicians that will have MD, PhD degree, or at least that they will be a research physicians. And one of the ways to do it, it's very hard for a physician to hold a laboratory. And I think that there will be a shift for a computational biology science. Physicians will find it easier to do research using computers than to work in the lab after a day of seeing many patients or being in the operating room. So one of the things that I think it's very important that the physicians and the students will have the data to work with, because you can ask a question, but if you don't have the data, it's a very, it's a big problem. The thing is that it seems to me, and I heard it from physicians and deans from the States as well, that health institutions are holding their data to themselves. There is a reluctance to share data with others. And there are institutions that look at their data as a way to get profit from pharmaceutical companies and so forth. So we decided to create our own data. We call it the Jerusalem Center for Computational Precision Medicine, where we are sharing data between health funds, hospitals. We have a big data in the Israeli army of people that started when they were 17 years old, and we have data, follow-up data till they are over 40. And we have now projects that we are running, both students and physicians. We got funds for it, so they don't have to pay for getting the data. And I think that this is a very good startup for research physicians.
Do you think that, you know, in the days of old, as I call it, I went to medical school because I wanted to be the doctor. Now I have to have engineering capabilities, maybe technology capabilities, maybe. Are you opening and broadening the horizon then? Are we getting more people interested in medicine because of that capability, do you think? Dina, are you seeing a difference in the kind of people coming in?
I think it's a very small set of people that were debating between going to medicine or physics or computational science, and now they have the way to combine these two things. I think that this is a small set of students. Maybe I'm innocent, but I still believe that the young people that are coming to medical school, when they were little, they dreamt to help people and to treat people. And I think that one of my frustration is that during the medical study, we are losing it. Not only that we are not strengthening it, we are losing it. They become more cynical and they're less compassionate than they were when they started to study. And we decided to start a program. We had a lot of debates which subject to use to add to the regular humanities courses that we are teaching from the first year to in our country, to the 6th year of learning. And we decided to concentrate on palliative and end-of-life studies.
Interesting.
And we are starting from the first year, and like a spiral, we are developing it. And I'll tell you what, I think that when my students want to annoy me and they see me putting the stethoscope on the heart of the patient and holding his hand to palpate his pulse, and they say, Ben Yehuda, there is an application in the cell phone where you can know everything about the heart of your patient. I tell them that when I put the stethoscope and I hold the hand, I'm not just listening to heartbeats and murmurs, I listen to the heart. And so many times when I'm doing it, patients are telling me, I forgot to tell you that. And they tell me the most important and most intimate things that they should have told me before. So I think that it's really important. It's so important that the digital and the machine learning and the AI won't change us as physicians, and the reason that we decided to be physicians.
Interesting. Mark, do you see some of the challenges around deploying some of these new things? Physicians, because they want to be physicians first, the danger that we talked about earlier, people stopping things because it doesn't fit with my being a medical person, some of these new technologies that are coming in, because we're dealing with life and death situations, right?
Yeah, I think I'm almost more concerned about they're going to be over-dependent on them rather than under-dependent. I think especially younger physicians, they're all, they're very, astute at using these things. Obviously, some older physicians have more difficulty with them, but younger physicians have no problem using them. The problem is that they tend to become dependent on them and not on their clinical sense. Human beings are not easy to take care of. The analogy I always hear of is, taking care of humans, we always get compared to the airline industry. Well, if you want to make that comparison, then we're taking care of 75-year-old 747s that have no spare parts and are flying 24/7. It is not the same. So I think that's the problem. But, the loss of humanity is a problem. And then I think we have to keep readdressing. I was lucky after 4 months, got to see my 5-month-old grandchild this past weekend. And you know what? When you look at humans at that age, the interaction is human. They smile, they
touch.
They touch. Why? Because that's how we are wired. Okay. And that wiring doesn't change. And if you ever take care of very old patients, it becomes just like when they were children. I hate to say it, but it is true. That wiring is still there and never leaves, that dependence. And I think that is what, personally, why I love medicine. It makes medicine very unique because we touch people in that regard, and we need to keep doing it. And at the same time, use AI, use information, data, technology as a tool, but not as a substitute. So that's my concern more as we get younger people coming up, is that, well, it doesn't say it on this, it doesn't say it on that, so therefore it can't be true. And if you listen to the patients, it's the old story, and Dina knows it, that when you're talking to a patient, you've probably made it 90% of the time a diagnosis just from their history. If you listen to them, they'll tell you what's wrong with them. You got to know some medical back. They'll tell you what's wrong. The physical exam helps, maybe another 10%. And then I always looked at it, the lab test just confirms. And that's the thing that we have to be careful. Now, that is not to say we should not pay attention to innovation. I mean, clearly the fact that COVID struck beginning of last year, and Israel's about half vaccinated already, or a little bit more than half vaccinated. We've given out 120 million shots already in the United States. That's the miracle of innovation.
That's right.
10 years ago, that technology wasn't there. If we wanted to do it, we didn't know how to do it. Yeah. So we as the human race need to embrace innovation, but embrace it in a way that doesn't replace the humanity, as Dina said, that we need as practitioners.
Keep that whole curiosity thing going, to your point, Dina, about keeping you being a researcher all the time. Research this, make sure you trust and verify, probably is something that's important as well, right? As you go through this. We've got, I think, about 10 minutes left, I think. Couple of questions that have come up. I'm not sure we can answer this one around inequality, but there does seem to be a trend happening with digitization that we are in danger of creating two tiers of healthcare, right? Those that are digitally savvy can do things because they have internet and Wi-Fi, and the hospitals can afford these systems, and those who do not. Is there anything you guys are thinking about around that inequality? Are we in danger of creating such a beast? Mark, you're nodding first, so maybe I'll go to you.
I have a real concern about that, because I think COVID has brought it out. I'll pick a simple example. Vaccinations. You have to get online to make an appointment in the United States on the computer, because if you call the phone number, you'll be sitting there on hold. And even if you sit on hold, there are people who can't afford to have a monthly plan that's unlimited messages. They may talk time. They may have a phone that, they have 60 minutes of talk time for the month. They can't afford to do it that way. We have older people who clearly are not capable, and others, just like we have regular health literacy issues, I think we have digital health literacy now. So we need a way to figure out how we can accommodate that as an issue. I don't see that with the younger people. I don't even see it with middle-aged people. But, I can only tell you that my wife was calling for my aunt and for some of, my mother-in-law's friends to try and get appointments for them online because they were totally incapable of doing it. It will be the same thing with telemedicine. Telemedicine can be very simple, but people are going to have to wear sensors. They're going to have to understand things. Getting back to security, they're going to have a Wi-Fi where their administrative name and password are not admin and password. We need to, because otherwise their data can all be stolen. We need to figure this out in the next year or two, because there is no doubt that this is going to be a methodology which it will not replace office visits, not replace hospitals, but will be part of it. And, you may have an 85-year-old patient and you say, well, someone else will help them out. Well, their spouse is 82 and can't do it any more than they can do it. So we have to figure out how these innovations are applicable to the most vulnerable, whether it be based on age, healthcare equity because of socioeconomic reasons, whatever. And that will be, I'm sure it'll be solved, but it's going to be difficult for the next year or two.
Are you seeing the same thing, Dina? I know Israel is renowned for innovation and technology and all of that. What's your?
I agree 100%. I agree with every word that Mark said. And I do believe that I do believe that people that know how to prepare the programs will come with a solution for it, because I'm sure that it can be done, but right now we don't have the technology for it.
So the guidance to the people who are listening in on us is, hey, if you can figure out a way to bring this to the masses, to the lowest common denominator, you're going to do very well, right? Instead of focusing on maybe some of the higher end things, perhaps.
And I would just add, for the people on the phone, you know, on the rest of the participants who are listening, you know, we're talking about still Israel and America, which are very industrialized countries.
Yeah.
But think of all those nations where, yeah, people have cell phones, but the industrialization is not the same. And the digital health literacy issues will even be more significant. So as a global problem, it's greater than probably either than in Israel or in the United States.
How do you think about then, when you're either evaluating, Mark, at Northwell, a piece of technology or something to bring in, or Dina for teaching, you know, this is where we're going. How do you think about the evaluation of it? What do you sort of in your mind go through to say, yeah, this looks interesting, I'm going to go do it, or this looks interesting, we should teach this now going forward? And maybe I can start with you, Dina. Is there some curriculum you've put together, or are you looking at trends, or how do you decide what to teach?
So we're very fortunate because we have a few computational physicians in Hadassah that I recruited for this mission. And together with the computational science faculty and with computational biologists, they built a very fundamental program, but also for the more advanced students, a more advanced program. And I think that they will have to change this program, not like an anatomy or physiology or pathology that we didn't innovate very much in the past decades. I think that we'll have to adjust it to the changes that are so fast all the time. Right now we are in a very solid place, but I'm sure that 2 years from now we'll have another program, no doubt.
Yeah. Mark, how do you think about these?
Well, there are a lot of shiny objects out there.
Yeah.
Informatics people want every one of them. And other physicians want every one of them. So what we try to do is look at it. What value does it really add? What's the impact either on operations or on patient care and safety and quality? The second thing we look at is we try to bring in frontline staff who would be using it and say, please give us your evaluation. You know, I may sit up in corporate and have certain thoughts, but I'm not there doing it every day. And those are the people we need to do it. And if it's something that's patient facing, we try to actually go to patients, and, you know, we have, you know, people that we use on advisory boards and stuff like that, and go and say, tell us what you think. You know, does this make sense to you? Would you be happy with this product? You know, would you think that it would help you, or you just, and so we kind of evaluate it at all three levels, because fortunately there's a lot of stuff coming out. Unfortunately, we can't do it all. There's not the resources, you know, the money. And in addition, not everything is as good as it's billed. And that's not unfortunate. You know, that's not bad, but it's just the reality of the world. So we kind of go through those layers to figure out how we're going to use it and if we're going to use it.
I think, you know, if you look at what the trend seems to be, everywhere you turn, everybody who's doing the technology world are saying, we're going to improve the patient outcome, or we're going to make the patient in charge of their own health. There seems to be a lot more focus on the patients and giving them either data or, as you said, on the phone, I've got my app with all my stuff in it. Do you evaluate any of those with the patient in mind, Mark?
Yes, we do. So, for example, we use one program now for when we have patients coming in for, let's say, colon surgery. And before they come in, there's certain things they have to do about eating, this and that. And then, so they answer that on their app. And then when they're discharged, literally the algorithms ask you every day, have you been done X, Y, and Z, and ask how you feel. And it's got enough smarts to it from AI and machine learning that if you answer certain ways, the nurse will probably call you up because they'll get a little blip that, things aren't going as well as they should. Okay. Or it may even say, please call, please, it sounds like you call the doctor right away, go to the emergency room because of what you're complaining about. And we're starting to use those tools more and more because there aren't enough people to keep calling everybody. One of the big challenges we're going to have over the next 20, 30 years is, fortunately, the population is aging because we can take care of people more, keep them alive. Things that used to, when I was a trainee, that result in death, when they were 60, we now take care of, but now they get conditions at 70. We can take care of those. Now they get other conditions at 80. So healthcare is going to become more complicated and much more rigorous as these patients age, and we will not have enough people to do it. So we are going to have to use and figure out again how the patient can use it, digital solutions to help augment what we do, because this is going to be much more of a complicated issue than it was when we just took care of people in their 40s and 50s. You took care of them, they got better, then that was it. That's not the situation anymore. Fortunately, because we can't keep people alive.
Right. But there's a downside to that as well, right?
A challenge, not a downside. I say a challenge.
A challenge, right? Or an opportunity if you're being.
Or an opportunity, right? For those on the
phone. So there's an interesting question that Khalid has asked. I'm not sure if Khalid is still on, but it's an innovation that's going on. There's pockets of these going on everywhere. This is an interesting one around things like 3D printing and growing organs, and technology using those kinds of ways to change things. What are some of the innovations? For example, in this one, growing organs or printing organs, is that a thing that's going to take off? Is that something that we see more and more of? Dina, you're nodding, so maybe you can answer
yes,
that.
we have such a program in our faculty, both for organoids, but also for organ printing. We also use human on chip.
Oh, wow.
Human on chip, where you can take samples from patients and in a cheap way that you can add drugs or know exactly what's the best way to treat. And one of the, now I'm saying my opinion, but one of the advantages will be that we will have to use less and less animal models, which I think that are problematic models because they are not human. And I think that using big data and these methods will come more and more to test things in the laboratory that are directly human and not animal models. So we think that it's a very important methods to develop, and we have people in our faculty that are working on it very seriously.
Amazing. Are you seeing anything like those kinds of innovations, Mark? I've seen those, 3D printing of, appendages or plaster casts and things like that. But I hadn't thought of the organ things that Dina just described.
We are doing some of the organ things. We've implanted 3D substructure when people lost their trachea, their windpipe from things. So we've done that. A very practical solution was actually during the peak of the COVID crisis last year in April, as ventilators were getting very scarce and we had, so many patients who need them. We had a bunch of a type of ventilator that was older, very good. We had a whole bunch of them, but to take care of these very sick patients, they needed a certain kind of tubing and therefore also these little Y connectors. Unfortunately, there were none of those Y connectors available in the country or anyplace else. So we took some and we gave it to our 3D printing people. They were able to print it and make it. We tested it. And that gave us 150 backup ventilators that we wouldn't have had otherwise.
Wow.
So
we did the same in our physics department in the university.
So again,
Amazing.
This is the value of innovation. And great innovation is you develop something so you can 3D print things for McDonald's, all right, and it winds up that it saves lives. But maybe the technology was designed for a whole nother purpose. I think that is the key in healthcare, is to not only look what's designed for healthcare, but what's designed outside of healthcare that we can use.
So do we see a future where this hyper connectedness of digital with the human physician making decisions and these capabilities changing the hospital, right? We've got a structure that's been built from the 50s, I guess, right? With departments and environments. Do you see a change coming, do you think, in the way even the buildings are structured and the way the care is delivered, Dina?
This is the whole idea of the bioconvergence, right? Where physics and mathematics and chemistry and biology and medicine comes together, trying to use things that they are familiar with and know to our purposes. I think that one of the very common example is nanoparticles that were physics only, and we are now using it to deliver drugs. So it seems to me that bioconvergence is the next thing that will help medicine a lot, because there are things that were developed for other areas that we can use in medicine and will help us a lot. So I think that this is one of the newcomer to improve medicine.
In the last few minutes that we have, on top of those things, is there something you can point to for this year, Dina, that you say, you know what, this is a new thing that I'm seeing that's emerging in the environment you're in that will literally change or innovate the way we're doing medicine? Is there one you can point to? Do you have a prediction for us? And if it's a company, I'd like to know the name of it so I can buy stock. No. Is there something?
Maybe Mark will
Okay. Mark, are you seeing anything?
I think the big thing for the next 3 to 5 years is going to be machine learning and artificial intelligence.
Okay.
More machine learning, because that's really, artificial intelligence by definition is you just basically teaching it and giving it the algorithm. It's really the deep neural nets and the machine learning. I believe, as Dina said, the symbiosis between that and humans and learning that interplay, I think is going to make a big difference, because instead of getting the pop-up alert on the EHR, which everybody disregards, I think what will happen is, the super kidney specialist doesn't need to know about X, but the first year trainee needs to know about it. Even simple things like that, I believe, will make, safety and quality improve, because it's going to be more individualized, not only for the patient, but individualized for the practitioner. so that the practitioner isn't annoyed by things they should know. They already know, and so they've learned that practitioner knows how to do that, but somebody else doesn't. I think that will make, I see as a big step in the next couple of years.
Interesting. Thank you. What about you, Dina?
I think that the most important thing that as a physician that I hope that the AI and the machine learning will do is create a better EMR, medical records. Because I think that the medical records that we have now, though they are digital, they are the same like the paper records that we had before. And for me, the fact that when I see a patient, I can't have a longitudinal way of looking at him. And if he did his MRI in another institution, I can't get the results. And the fact that the digital records do not have the voice of the patient. And a lot of things that makes the medical records not a predictive tool. So let's say if I'm following up a patient with lymphocytosis and I want to know a minute before he develops his chronic lymphatic leukemia, I have no way to do it. It's the same as it was when I had the paper records. So I hope, and I know that Microsoft and IBM and many other big companies try to do it without success. But I really hope that very smart young people will develop the ideal medical record, because the way that we are dealing with our patients now is not the right way to go. And it's not integrative record. You know, if the patient saw endocrinologist for his diabetes, and now I have to start steroids on him because he has lymphatic leukemia, I know nothing about his diabetes.
Yeah. Interesting. So it goes, we've come full circle to part of it is knowing the patient, really getting to know the patient, whether it's the humanity of the patient or whether technology can help us get to know the patient, right? At the end of the day, that's what this is all about. Thank you so much. We're at 1 minute past our time. Dina, I know it's late, so really thank you for joining us and giving us your wisdom. And Mark, always thank you. Real pleasure. Thank you, everybody. Thanks for joining us, and we'll carry on with the main stage and for the next sessions.
Thank you.